Welcome to the Medical Report. We have an interesting discussion today about a topic that is kind of new to me by terminology, but not by fact. But the term is called Boomeritis, B-O-O-M-E-R-I-T-I-S. And with us to discuss that particular title is Dr. Todd Michener. Dr. Michener is an orthopedic surgeon with the Chester County Orthopedic Associates. He is probably the fifth of that particular group that has spoken to us, and I think as a group we've learned an awful lot about bone and joints. So Todd, thank you very much for joining us. And Todd is a graduate of Vanderbilt University Medical School. He went to University of Virginia prior to that and took his orthopedic training at the University of Pennsylvania. So we have a very talented and well-trained individual with us today. One of the term Boomeritis, it was new to me when you first told me you were going to speak about that. Could you explain what Boomeritis means?
Sure. Boomeritis really refers to any sports-related injury in a person of the baby boomer generation. And so as people continue to be more and more active later into life, we're seeing more sports-related injuries that we weren't seeing before. And my job as an orthopedic surgeon in sports medicine is to keep people active and doing the things that they want to do at any time in their life. And so Boomeritis is sort of this term that's been coined, and we use it pretty regularly.
Okay, so now we know what Boomeritis is. So it's an itis of everything that involves the joints, I guess, at some point. One of the first topics of this is something called epicondylitis. That's E-P-I-C-O-N-D-Y-L-I-T-S, epicondylitis. So I know maybe we'll have this spelled out for you on the screen at some point in time, but could you explain to the audience what epicondylitis is?
Sure. These are terms that you've traditionally heard as tennis elbow or golfer's elbow, and we call that tennis elbow is referred to as lateral epicondylitis, which is inflammation of the tendons on the outside of your elbow, and golfer's elbow is medial epicondylitis, which is inflammation of the tendons on the inside of your elbow. So those are probably one of the more common things that you will see later in life as you continue to be active playing various sports or even just doing your normal activities of daily living, and can be quite debilitating.
Yeah. So epicondyles are anatomical locations, right, of the bone.
Correct.
And so the surface area over them is inflamed. Is that the process?
Pretty much. The end of your arm bone, your humerus, like you said, has epicondyles, and various tendons and muscles insert into that area, and you get irritation of those muscle tendons that cause pain.
So it's more of a soft tissue injury rather than a bony injury.
Correct.
Okay, very good. So when you say tennis elbow, what are the common causes? I mean, playing tennis, obviously, if it's called tennis elbow, but correct, what actions cause tennis elbow?
Typically, the terms tennis and golfer's elbow, I think, are not truly accurate, because I always say about 98% of people that have either one of them don't play tennis or golf, and it's typically just a repetitive use of that arm, reaching and grabbing, pulling, hammering, painting, scrubbing. Those types of repetitive activities can cause problems in this area.
So these pains that develop are located right on the outside?
Typically, the most common one would be tennis elbow, where people get a sharp stabbing pain on the outside of their arm when you go to grab a doorknob, shake somebody's hand, or you try to pour your coffee mug or grab a gallon of milk, and they get this sharp stabbing pain right in this location.
So anything that causes any kind of a rotational motion is going to aggravate it, I suppose?
Correct.
Yeah, okay. So when you get one of these inflammatory episodes, is there a distinction between an acute form and a chronic form?
Yes, there is. I think with an acute form, it is due to over a weekend or some specific activity you've been doing, you start getting this sharp stabbing pain that sits there. And so in those, and how we treat those are a little bit different. So when we're in an acute form where, this past week or a couple weeks ago, it's really started getting irritated, the best therapy is rest. I'll often put people into what I call a cock-up wrist splint that will allow, hold the wrist in a relaxed position to allow these muscles that have been irritated to calm down. And typically some sort of anti-inflammatory medicine like ibuprofen, Advil, Aleve can be helpful during the acute episode. Sometimes a topical anti-inflammatory gel can be helpful as well.
So if one of our more enthusiastic golfers takes the larger than usual divot that upsets our greenskeepers,
Yes.
what will happen to his elbow?
Depends which side it is. If it's your lead arm, if it's your lead arm, you'll get tennis elbow. If it's your follow-through arm, you'll get golfer's elbow, and that's how you get golfer's elbow. But a lot of people, when you hit it fat, the repetitive nature of coming down will really irritate their left arm, if they're right-handed, their left arm, and it will become quite sore. So hopefully you only do that once or twice around.
And I hope that's good prevention
Exactly.
explanation to our viewers here. That's wonderful. So you said something about Aleve or topical thing. What other treatments are usually used for these disorders?
Yeah, once you get past that acute flare-up and this becomes a more persistent or chronic problem, typically I'll do a few things. If it's been going on for a while and it's been quite painful, sometimes we'll consider a cortisone shot into the area of maximum tenderness. We call it lateral epicondylitis, and we think of it as inflammation, but after a while it really becomes more of a degenerative process, and so but we still treat it like an inflammatory process. So a cortisone shot will be something I will consider. Then we typically get into a stretching program where we work on stretching our wrist this way, and that will tend to stretch the muscles. And then after we can calm down some of the pain, then we work on a strengthening program that will help make this go away.
Is surgical intervention ever necessary for either of these?
It is, in rare cases. I would say 98% of the time these are typically tend to be self-limiting problems, and it's after, if you've had symptoms for more than 6 months, you failed sort of exhaustive conservative treatment, sometimes we will require surgery. And there's two ways that you can do that. There's one, open, where you go in there and you remove the diseased area, or there's an arthroscopic way where you just make two little poke holes and go in with a little camera and remove the diseased area. And that's typically the way I do it because there's less soft tissue injury. I don't have to violate any of the normal structures to repair the problem, and it typically is a quicker recovery that way. But again, most of the time surgery is not necessary.
Well, let's move up the road a little bit from our elbow to our shoulder.
Yes.
These athletes around here really are worried about their shoulders
Absolutely.
too, and so the first thing we're going to talk about is a frozen shoulder. This is something that's fairly common, isn't it?
It is.
And could you describe to our viewers what a frozen shoulder is and perhaps what causes it?
Sure. A frozen shoulder is not the most common. Well, one of the common issues I'll see in the shoulder that can be quite debilitating, actually. And what it is basically a painful shoulder that ultimately loses its range of motion. And so if we look at a shoulder is a ball in a socket, and there's muscles on the front, top, and around the back. That's your rotator cuff. But underneath it is the capsule, which has the ligaments and everything that holds the shoulder together. And with a frozen shoulder, the capsule in the shoulder becomes very inflamed, very irritated, and over a period of time it thickens up and your motion becomes quite restricted. Okay. And it can be extremely painful.
And what are the most common causes of frozen shoulder?
So one of the more common causes, the most common cause is probably idiopathic, meaning it just happens for whatever reason. It typically happens more commonly in females than in males. Typically between 40 and 70 is the average age range that you'll see it. People with diabetes, cardiovascular disease, or hypothyroidism are a little bit more likely to get it. But that's the most common form. But then you also have post-traumatic, meaning you slipped and fell and you injured your shoulder. So in those cases, the best treatment for that is preventative. So you slip and fall, you injure your shoulder, you go to the emergency room, you go to your doctor, and they shoot an x-ray, nothing's broken. sometimes they'll put you in the sling. And the first thing I do is I say, get rid of that sling, because if we just keep you immobilized this for a period of time, you will stiffen up, and you can stiffen up rather quickly. And then if we develop a frozen shoulder, it can be quite debilitating. And
So the message is, even though it hurts, you need to start moving it a little bit.
yeah, gentle. I say always take a nice
gently.
hot shower.
Gently, yep.
Use that moist heat to sort of help loosen you up and start moving it around.
Try to take it through the range of
Exactly. Just gently walk your hand up the wall. Use a cane or a broom to sort of gently move your arm side to side.
Does that ever require surgical intervention?
That does occasionally. Most times with a frozen shoulder, again, it in itself is self-limiting. I say the natural history is it will get better with time, but it can take 18 to 36 months to get better. Sometimes even if you have some of diabetes or some of these endocrine issues, it can take up to 4 years to get better. And so I always say there's many phases to a frozen shoulder. There's sort of the freezing inflammatory phase where it's really painful. Early on you may get misdiagnosed with tendonitis or something like that because your motion is pretty well preserved. But then after that we sort of see then you freeze up, and that can take 6 to 9 months to develop. And then you get the frozen phase where the pain subsides, and then there's a thawing phase where gradually you regain your range of motion. So it will get better, but it can take a while. So our goal is obviously to make that happen at a much quicker pace.
Yeah. One of the things that people frequently ask is, what's the difference between tendonitis and bursitis? And is the treatment different, and so forth? Could you explain that a little bit?
Sure. The term in the shoulder, at least tendonitis and bursitis are exactly the same thing. And so you say, oh, my doctor said I had a little bursitis, a little tendonitis. The treatment is exactly the same. They are exactly the same thing. And really in the shoulder, that's called impingement syndrome, which means, again, you got the muscles on the front, top, and around the back, and then there's a bursa that sits above the rotator cuff, and there's this arch of bone up here, and I have a picture here to show you, but as you reach up to grab overhead, you're impinging the bursa and tendon underneath there, causing the bursitis and tendonitis. So they're basically the same, and the treatment's the same.
So we're going to talk a little bit about the rotator cuff, because this is one of the more important things, isn't it, that we need to talk about. So we're going to perhaps start with the rotator cuff issues. Perhaps you could explain to our viewers what the rotator cuff is, and then a little bit about what are the issues with it.
Sure. The rotator cuff is basically a collection of muscles and their tendons that insert around the shoulder and literally form this cuff of tissue around. So again, on the front, top, and around the back. And it basically allows you to move, arm to move in various locations. And so when you irritate the rotator cuff, and it typically happens with life, it's not doing anything specific. A lot of repetitive overactivity can cause it, but even just doing your normal activities of daily living can cause problems. And so what people typically will present with is pain, but it's not in their shoulder. It can be in their shoulder, but most of the time they'll complain of pain on the outside of their arm. And so they'll say, my arm hurts. It feels like it's muscular, but it's really coming from the shoulder. So that's the classic symptom of rotator cuff or any shoulder problem is arm pain. Typically hurts with overhead activity, reaching back to grab something, reach behind your back to put on a bra or wash back in that area can be quite painful. And just like any of these shoulder problems, often what brings them in to the doctors is they hurt at night. Night pain is probably the most common thing that laying on that side becomes difficult, or it keeps them up at night, and then they'll typically seek medical treatment at that time.
How do you distinguish between a rotator cuff problem versus a tendonitis or bursitis?
Well, so if you have rotator cuff tendon, the big difference I think is between tendonitis and bursitis and a tear. And I think it's really a spectrum of an injury. So you start out with tendonitis and bursitis, then you go down to a partial thickness rotator cuff tear, and then a full thickness rotator cuff tear. And they present all very similarly in terms of how the people feel. But the main difference is when I examine them, they're weak. And that's sort of the thing that differentiates it, is when I isolate the various muscles around their shoulder, if they're weak, then I'm more concerned about a tear.
So it's a physical diagnosis that really makes a distinction.
Correct.
We're going to come back for the second section Welcome back to the medical report. Our guest speaker is Dr. Todd Michener, who is an orthopedic surgeon with the Chester County Orthopedic Associates. Dr. Michener specializes in shoulder and sports orthopedics. And so far we've been talking a little bit about a few things like epicondylitis and frozen shoulders, and we were in the process of discussing the rotator cuff issues. He discussed a little bit about what the rotator cuff is and how he diagnoses what is a rotator cuff injury. Can you tell us a little bit more about the tears that occur and the degree of tears and what makes the difference in how you manage them?
Sure. There are a variety of tears. Like I said, there's a partial thickness tear where it doesn't go through the whole width of the tendon, and then there's a full thickness tear, meaning it goes through the whole tendon, and then that can become small, medium, large, and massive tears. It tends to be a spectrum of an injury. Most tears are not traumatic. So I hear a lot of people say, "Oh, I didn't do anything specific. I didn't slip. I didn't fall. I wasn't a pitcher." I say 85 to 90% of the tears that I see are what I call atraumatic. So they're just life-related issues. And again, typically, how my differentiating criteria is pain. Significant pain at night and significant weakness on exam is when I'm really concerned about a tear, and that will change how I will treat you or imaging studies that I will order based on that.
Sure. Now, getting back to diagnostic studies, what is the best diagnostic study to determine the tear?
The best diagnostic study to get a tear, to determine a tear, is an MRI or an ultrasound. X-rays are good for looking for arthritis, but not great for looking for a tear. But I'm very selective on who I order an MRI for, because we don't just want to order an MRI on every person, because I decide if it's going to change my course of treatment is when I'll order an MRI.
Okay. So when is surgical intervention indicated?
Typically, surgery is indicated for somebody that has persistent shoulder pain or weakness that's failed conservative treatment and failed injections, physical therapy. The concern about having a full thickness tear is it gets bigger with time. In the natural history, if we don't do anything, that small tear will become a big tear over time. And so if you have symptoms of pain or weakness, and I know you have a full thickness tear, depending on where we are in life, I will consider fixing it to prevent, to treat the symptom as well as to prevent progression of that issue.
Off the top of your head, is there a percentage that requires surgery, would you say?
I think of the full thickness tears, more than 50% will require tears. Probably 75 to 80% of full thickness tears will require surgery.
And what about the outcomes? Is that most of the time, is it successful permanently?
Yeah, the surgery, nowadays we do everything arthroscopically. Very few people will do it open anymore. The results are as good or better if we do it arthroscopically. So that means just making little poke holes around the shoulder and going in with a camera and repairing the tissue that way. So it's less traumatic. It's still a significant recovery, but the overall results are very good. Pain relief is almost universal. 98% of people get good, excellent pain relief. Function in terms of overall use is directly related to how well the rotator cuff heals. And so smaller tears heal better than bigger tears, so we rather fix them when they're small than when they're big, because the functional results are better that way.
Is there any particular movement or activity other than falling down the stairs or something like that is commonly associated with this? I know you said some of them are not related to physical activity, but is there any repetitive thing that can precipitate it?
Absolutely. I think repetitive overhead activities, painting, hanging pictures, nailing. So I say any sort of repetitive overhead lifting activities is not a good idea. And when you're going to the gym and working out, like they have you doing these weight machines overhead, I tell anybody over 30, that's sort of my rule of thumb, is I don't like you to do that with weight, because that sort of can lead to rotator cuff irritation, not necessarily tears, but problems.
I've been doing that every day for years.
I know.
I better stop doing it.
Well, I just say, because I say that's when I start seeing people having that problems, and so to make that less likely of an issue, I would avoid that.
All right. Well, that's a pretty good summary of that. I think, I hope our viewers understand now the difference between what epicondylitis is and what the difference is between a frozen shoulder and a rotator cuff problem and a tear and just a pull. So we're going to move on a little bit now to non-arthroplasty. So can you tell our viewers what non-arthroplasty is?
Well, I'm a sports medicine doctor, so my goal is joint preservation. So preserving the joint in any way in which we can. And as opposed to arthroplasty means joint replacement. And so my goal is to get people with arthritis, to treat their symptoms without requiring a joint replacement surgery. That's sort of the end stage. The last resort is doing a joint replacement. So non-arthroplasty means non-joint replacement procedures or treatments.
Now you're talking about all the joints that are most commonly replaced, like the knee.
Yeah. The knee,
the
typically
hip,
in regards to the
shoulder.
There's typically the shoulder and the knee. The knee probably is the most common joint replacement out there. So when I say non-arthroplasty, I'm really referring to the knee typically.
And the hip too as well. Are we going to talk a little bit about that?
Not too much about the hip,
Okay.
more about the knee.
All right. So let's start with the question: who is a candidate for non-arthroplasty?
So these are people who do not have diffuse arthritis throughout their knee. So it's they're in the early stages of arthritis, or it's only isolated to one part of the knee and not throughout the knee, are candidates for this kind of treatment.
And this is a localized problem within the knee?
Yeah, typically, if that can be related to, it can be meniscus tears related to arthritis. It can be joint contractures that happen as arthritis advances. There are some techniques that we can do to sort of increase the joint volume.
All right. So tell us then what you will do for these folks.
Well, typically, first thing is strengthening and exercise. And exercise, I always say motion is lotion. So exercise is important, but the type of exercise you do is important, that you don't do activities that make the problem worse or exacerbate the issues. But strengthening is very important. So keeping the muscles strong, not only do your muscles move your joints, but they also absorb energy. So as you're walking and doing various activities, the stronger your muscles are, the more energy they absorb, the less that is transmitted to that joint. So that's probably the first thing, is strengthening. Flexibility is very important. So as we continue to mature in life, it's important that we spend adequate time warming up and then working on stretching. So I think as we're all rushing around, playing golf or doing whatever activity, we don't give enough time to stretch, and that plays an important role. And so that is the sort of the basic what I'll do, and physical therapy is incorporated in that. But if we have an exacerbation of pain, sometimes a cortisone shot can be helpful. Sometimes these lubrication medicines, which I'm sure you've heard about for arthritis, are extremely helpful to keep people active, and we can do that every 6 months, and that's been shown to be beneficial in terms of relieving symptoms. And also there's some theory, not quite shown yet, but theory that it slows down the progression of the disease.
The injection of this viscous material?
Yeah, so this lubrication medicine.
Okay.
Orthovis, Synvis, Halgan are the common types that you'll hear.
Now, what about walking? There's a lot of folks like to walk.
Yes.
And somebody who has, say, early degenerative disease, perhaps that you could help them with medical management rather than with the surgical procedure. What's your advice to them about walking, shoes, and so forth?
I think walking is very important. I think it's important to have a shoe that has a lot of cushion. So again, that sort of helps with the shock absorbing area. So again, and surfaces make a difference. If you find walking on the road or the concrete's hard, is difficult and it makes your pain worse, then I typically tell you go on a softer surface or a track at a local high school where they have more forgiving surface is important. I think hills flat surfaces are better than inclines, because you'll find people in hilly neighborhoods tend to have a lot of more problems with their kneecaps, pain in the front of their knee, Flat surfaces definitely are a better choice if you're walking and have knee problems.
So it's kind of hard to go uphill both ways, isn't it?
That's
And,
true.
And downhill seems to be harder on the knees than uphill, right?
Absolutely.
Okay.
Just like going down the stairs tends to be worse than going up.
All right. So if someone has a meniscus tear, for example,
Correct.
are you going to be able to treat them by non-arthroplasty?
Yes, meniscus tears, if you have a symptomatic meniscus tear, that's probably the easiest thing treated without a joint replacement. If you tried the medical management, or we tried some injections, but if you have pain localized specifically to where the meniscus is, and we talk about the meniscus, we're talking about the shock absorber in the knee. Can you see that? So these are these little C-shaped structures. That's a shock absorber to your knee. So if you have pain localized to that area in a degenerative meniscus tear, we can go in there arthroscopically and remove that torn meniscus. Can't get rid of the arthritis, but we can get rid of that sharp stabbing pain related to the meniscus. Can't get rid of the arthritis, but we can get rid of the sharp stabbing pain related to the meniscus.
Okay.
And that's a great option. And at the same time, if I know somebody has some arthritis in their knee, what I do is there's a gentleman, Dr. Stedman, who sort of pioneered this treatment for people with arthritis and other issues in the knee, where you basically inject fluid at the time of surgery, and we try to distend the joint, and then I'll also release some contractures and scar tissue in the knee that has actually been shown to be very helpful in eliminating the symptoms from arthritis.
Okay. Now, can we apply any of this non-arthroplasty to the shoulder?
You can. Similarly, the injections are very helpful. The lubrication medicine are also very helpful for people that have arthritis of the shoulder. And the FDA hasn't approved it, but it's an off-label use. Studies show that it works in the shoulder, and I will often do that for people with arthritis. Again, most people that have shoulder problems, 90 to 95% of them are rotator cuff or frozen shoulder, and less likely arthritis. Unlike the knee, where most people it's some sort of arthritis-related issue.
So what are the outcomes of this overall? What's the success rate of say, non-surgical intervention, let's put it that way, in treatment?
I think non-surgical intervention is good in the appropriate person. Unfortunately, the natural history of arthritis is it's going to get worse with time. Yeah. And so our goal is to slow down the progression of that disease, treat the symptoms accordingly, and preserve that joint as long as we can before people ultimately need a knee replacement. So if we can get you later on into life with your normal knee, the more successful that knee replacement will be, and less likely that it will need to be done again.
Well, this has been a really terrific discussion. I wonder if there's anything that I haven't asked you that you thought you might talk about today.
Sure. I think he's addressed a lot of the issues that I want to talk about, but I can't emphasize the importance of warming up and stretching. And so, it's important to work on your cardiovascular exercise, work on your strengthening. Strengthening has been shown to maintain muscle mass later on to life, and there's benefits up into your 80s and 90s to continue doing resistant exercises. And I can't emphasize enough the importance of stretching. That's about it.
So, as a demonstration of my exercise pattern, can we do an arm wrestle here this evening?
That sounds good.
I'm just kidding. I might beat you.
I know, that would be embarrassing on TV.
So, I really think this has been wonderful, and we thank you so much, Dr. Michener, for joining us, and I'm sure our viewers have enjoyed it.